everybody, and welcome to DocTalk. I am Dr. Erin Knopf.
I'm Dr. Corinne Hannan, and we are so excited to have our visitor here today, Dr. Elizabeth Wassenaar. Please, would you do us the honor of introducing yourself to our very population?
I will, yes. Hi, I am Dr. Elizabeth Wassenaar. I am a child and adolescent psychiatrist, and I am the regional medical director at Eating Recovery Center for our West region. I am in Denver, Colorado today. That's where I live. I trained in a residency program that was pediatrics and psychiatry. So I have the honor of training just like Dr. Knopf in that way. And also have done a lot of extra sort of work on training for psychotherapy. I really enjoy doing psychotherapy and believe in the healing power of therapy.
So, Dr.
I just
Wassenaar,
gonna, I'm actually gonna brag. Can I brag on
well, I
Dr.
was going to
Wassenaar a little
say
bit
she's
more?
a unicorn like you, like really hard to find people that are experts in so many areas, but please brag.
We have to brag more. So, Dr. Wassenaar, yes, likes psychotherapy, but she's actually psychodynamic trained. She has done so many other additional trainings outside of residency. She's a lifetime learner. There's so many things we could say, but yeah, I wanted to really name just how brilliant you are, especially psychopharmacology, too. Let's not forget that. All right, I'm done.
I mean, it's so nice to have two unicorns in the same room. Thank you all for being here and for your work. So, Dr. Wassenaar and I were chit-chatting before this recording about higher level of care in eating disorder, the eating disorder world. Dr. Wassenaar, would you break that down for us, what higher level of care means?
Yeah. So higher levels of care are basically all the levels of care that are more than outpatient. So that's not to say that outpatient can't be quite intense. You can be seeing your outpatient providers, your therapist, your dietitian, your physicians several times a week even. But at the higher levels of care, we have starting from sort of the highest and moving down, we have an inpatient level of care, residential level of care, partial hospitalization level of care or PHP, and then intensive outpatient or IOP, which oftentimes can be also provided in a virtual setting.
Okay, so just so in case people still don't know what that means, can you start with like what inpatient versus residential means?
Yeah. So, inpatient level of care for eating disorders is a level of care that we essentially use for people who have very severe medical and psychiatric complications for their eating disorders. They need a lot of medical and psychiatric support. These are 24-hour levels of care. So, both residential and inpatient are 24-hour levels of care, which means that you have staff support, medical staff support, like nursing support. 24 hours a day. And what that means is that you may have more significant complications. You need more medications. You need more support with maybe even getting around a unit because your muscles are weak or you're feeling tired. Or there's concerns your blood glucose could fall. So inpatient level of care is really the highest level of behavioral health support. And at the inpatient level of care, as psychiatrists, we are often able also to provide additional support if there are other concerns, like if you are also struggling with safety or self-harm, or if you have other psychiatric or mental health conditions that are really impactful on your ability to function. We also can have a conversation for people who may struggle to recognize the severity of their illness and might need somebody to help them stay in treatment when they think that they don't need to be there. And that's a very sensitive and complicated issue that we can talk more about, but that is sort of the inpatient level of care.
Perfectly said. Thank you. So inpatient's the highest 24-hour support. Residential also has 24-hour support, but it's like a little less intense.
That's right. Yeah. Less intense. Usually you are able to access some of your own resources a little bit better in terms of interrupting eating disorder behaviors or practicing safety. But oftentimes residential levels of care still provide a lot of support. Like they might still lock the bathrooms after meals so that you don't feel the urge to go use a behavior and the staff can support you with practicing new skills. There's still going to be support overnight. So if you wake up in the middle of the night with a panic attack, there's someone there to support you. And so I think that it's nice to think about the residential level of care as still providing that real wraparound 24-hour care, but you're beginning to practice on your own. You're able to access some of your own skills independently.
Beautifully said. And then PHP, a lot of people don't know what partial hospitalization programs mean. Is that about an 8-hour a day program?
It's variable. So at ERC, our day program is actually close to 12 hours a day, and we provide care from first thing in the morning. So you get up, you come right in. We support you with breakfast. You're with us through the day, through snack, lunch, snack, dinner, groups, individual appointments. And then after dinner, you go back to your own home or an apartment with your peers and have a few hours in the evening to practice what it would be like to not be in intensive treatment. So it's still quite intense and there's a lot of support. Generally, with the partial hospitalization level of care or day programming, as you start to work through the program, you become eligible for passes or time away from program to practice what's real life going to be like. Am I going to be able to get myself out of bed and make breakfast and eat that breakfast the way that I need to? So it's an opportunity to sort of start to practice with a little bit of time out of program, but not a lot. So there's still a lot of support.
And you said it varies. So 12
Mhm.
hours is maybe your
Yep.
standard, but people could do
Yep.
less hours. Okay.
Yeah. So as you get better, you have an opportunity to practice with less support. I will also say different programs have different structures. So our program happens to be structured that way, but if you are looking at partial hospitalization programs, I think it's important to ask, what's the schedule like? Is it 5 days a week? Is it 7 days a week? So that you can think about what's going to meet your needs.
Yeah, the one that's nearby where I practice, they do an 8 hour a day and they do 2 meals, 2 snacks, but then you're kind of on your own for the last meal of the day. So that can take a lot of preparation. So well said, like to really research what your options are, what you need, what kind of support and flexibility works for you. Because some people are trying to still hold down a job or go to school part time, things like that, right?
Right, right.
I think too, is it the minimum 6 hours for PHP from an insurance perspective? Like,
That
I
is a
not that
good
we want
question.
insurance dictating care, but I
Yes.
know it happens. But I think
Yeah.
that's the minimum.
I think you're right that you have to be in program for 6 billable hours. So,
Yeah.
what that means is that it's not meant to be set up that you are coming in for 2 hours here and 3 hours there. Oh, you are committing to doing a pretty significant chunk of work in a PHP program. And I would say it is hard to work a job or go to school or take care of a family when you're in a day program like that. At the end of the day, our patients are exhausted. It's hard work. So I want to set realistic expectations about how much life you can live outside of PHP. I want people to be able to practice with watching TV in their own bed when they fall asleep and interrupting their eating disorder urge to exercise before they have breakfast. But there's not a whole lot of time outside of program.
That's well said. Thank you.
And another thing to name too, which is actually a wonderful perk of ERC, right? Is it's 7 days a week PHP programming versus there are 5 days a week, Monday through Friday. So that makes it a little different too for weekends.
Well, and it's such a great interruption of that perfectionism of like
Mhm.
doing it all, like including
Mm,
your care in a hospital while you're still working, going to school.
yeah.
I've worked with a lot of people who've tried to do
Yeah.
that and it didn't go well. So well said.
It's so true. It's so important to give yourself the time to do the work you need to do. Your
Yeah.
eating disorder is crafty and it's hiding in the corners. If you don't take the time away from your life to really look at all the ways that it's impacting you, I think it sets you up to potentially have a relapse, which is, you just put in all this time.
Yeah. Okay. Then after PHP, the next step down from intensity of treatment is IOP or intensive outpatient. Can you just give a little spiel about that?
Yeah, so intensive outpatient is usually 3 or 4 hours, 3 to 5 times a week. So it's about 9 to 12 hours a week. Usually it's a lot of group programming. So psychotherapy groups, our IOP, when it's on site, we do a meal together in our intensive outpatient. And so there's some experiential, a lot of group work, and then some individual work with a dietitian, a therapist, perhaps a psychiatrist if your IOP is providing that. So it's much less intense. This is a level of care where you can think about going back to work. You can think about going back to school or taking care of your family. And I really encourage that when people are in IOP, that they are really in the mode of practicing what it's like to live in recovery. So IOP is a difficult level of care to do if you are still actively moving through treatment and trying to challenge your eating disorder. Not to say that every day in recovery there aren't challenges from your eating disorder, but I really, if you are still having weight to restore or you're engaging in eating disorder behaviors every day, IOP is a difficult level of care to get the amount of support that you might need. So I think that, as we talk about these levels of care, it's really important that as you're considering each individual out there listening, like, what do I need to challenge my eating disorder? To be really honest with yourself about how much is your eating disorder taking your life away from you? And how much support are you going to need to actually interrupt your eating disorder and get your life back? So IOP is a really fantastic level of care. It is a great transition out of higher levels of care, because otherwise you can go from 12 hours a day, 7 days a week to a couple of appointments a week. That's big transition. It can also be a really nice way, if you feel yourself starting to slip, to get into IOP and do a reality check. Can I interrupt this, or do I need actually more support? So it's a really nice level of care to bridge both ends.
Okay.
I like how you really emphasized the opportunity to be honest with yourself, because I think this is where it's really hard to know where's self and where's eating disorder, right? And I think something I would share with a client or a family of a potential patient, when we talk about the criteria for being at different levels of care, aside from medical stability and percent of weight restoration that's needed, it really comes down to a couple of things: the frequency of behaviors, the willingness to do treatment. Those two are really big factors that determine which level of care is more likely to be successful versus just treading water and not making any traction. So I'm curious if you can speak a little bit more to, what does willingness mean? What does it look like? I guess this could be through the lens of, are we contemplating change versus, it can be with psychology of change, but it could also be a lot more than that. And then also the frequency of behaviors is really important. If you're restricting once a week versus restricting every single day, that changes which level of care would be recommended to you.
Yeah, absolutely. To your point, Dr. Knopf, I think it's a really good opportunity to take honest stock of what's happening. How much are you using behaviors? And I know it's really hard to be honest all the time, even with yourself, about how much the eating disorder is impacting you. So taking a couple days to maybe keep a little bit of a journal about how often you're thinking about your eating disorder, you're using behaviors, and really looking at that honestly with your providers to say, how much support am I going to need? How often in the day? When are my most vulnerable times? You might have an individual who actually doesn't engage in behaviors throughout the entire day, but then at night when they're alone, it's the hardest time. They might say, well, I'm only engaging in behaviors a couple of hours each day, so maybe I just need day program. But we can notice that your hardest time is 10 p.m. and day programming is not going to be enough. So it's really thinking honestly and talking honestly about what's really going on for you. And then I also think it's an important time to have a conversation of, how ready are you to do the work that needs to be done? I think one of the great lies eating disorders tell every person who has suffered with an eating disorder is, I'll stay small. I'll just stay in the corner. You don't have to completely eliminate me. I won't bother you, I promise. I'll just be here in case you ever need me again. And we know that's not true. Eating disorders are one of the most selfish diseases, and they will not tolerate being your second choice. If you think about how much support do you need to once and for all kick this eating disorder to the curb, and then talk about that with your provider and think about, what do I need to do this work?
That is so well said. It is so tricky to work with motivation and insight. And I think part and parcel with eating disorders, I'm sure we're all familiar, is just downplaying, minimizing. Yeah, I can keep some of it. I don't have to get rid of all of it, or it will just hang around for me. And it's a liar and a bully. That's what I call it. A liar and a bully. And it will tell you anything that it needs to tell you for you to believe it. And it does not have your best interest. The eating disorder never has your best interest at heart, but your team does, right?
That's right.
So you and I talked about a metaphor that I like to use with clients when I'm talking about the potential of higher level of care. And I like to use it a metaphor of like a broken leg, and that some people have a bone exposed. This is such a bad break. I'm, as an outpatient therapist, I'm crutches and casts. And if you have a bone coming out of your leg, I can see you for 1 second in my office and I'm like, we need to refer to the hospital. We need to go to orthopedic surgery, right? But sometimes it's not crystal clear. Is this a stress fracture? If we tape it up, can this start to get better? And sometimes people have very, very strong feelings about whether or not they're willing to go to a higher level of care for lots of complex reasons. And so I like to just say, like, and when you check in with your providers, let's determine the level of care that's needed. We can even give it a test run, but it doesn't mean it's a failure if I refer you to a high level of care. It means that we're really dialing into what you need, and we need to set the bone before we put on the cast. Anything you want to add or subtract or change about that metaphor?
No, I just think that metaphor is so beautiful. I really love it because everybody knows what it means to break a leg. But I think it can be really hard when people are talking about an eating disorder to appreciate how significant and severe it can be, and that there are levels of degrees, that one eating disorder and another eating disorder are not the same thing. Even if you have the same DSM-5 diagnoses, you with an eating disorder have a unique presentation.
A unique X-ray, right?
That's right. That's right. So I think it's just it's a really apropos metaphor. And I think the other thing that I would say is that, if you, as an outpatient provider, is referring you to a higher level of care, it is not a failure. It's because they actually believe that you can benefit from treatment. If they didn't think you could get better, then they would just say, well, I guess we'll just have to cast it and you're going to have to walk with a limp for the rest of your life. But the reality is that eating disorders are treatable and recoverable. And we have all seen people that thought they would never recover, and they are living in recovery. And so when your outpatient provider says, I think I've done as much as I can do at this level of care, we need to start thinking about how to get you more support, that is them saying, I believe that you have a better life on the other side of this eating disorder, and I believe that you can benefit from treatment.
Yeah, and to use the leg metaphor, it's like, let's get the bone set right now so you don't suffer and prolong this misery. And I fully believe that you can walk again without crutches and without a cast. But we also talked about that may not mean you're back to, hurdles.
Yes.
Whatever what is it called? Like the steeplechase
Track
or
things.
whatever.
Yes. Yeah.
But and it might be that, but you'll also have a vulnerability there that we always have to keep track of. And so having a team that's assessing and tracking and giving you the support you need, it is because we believe in you. It is because we can beat this. It is because you can recover and be well. And you and I were talking about how hard it is to do recovery, and higher level of care is intense. And I say to my clients all the time, yeah, this is going to be a lot of time, a lot of energy, a lot of focus, a lot of attention. And I don't know anything more worth your time and attention than healing your bones so that you may walk with a strong skeleton again.
That's right. That's right. It's exactly right. I just think it's so important that people know that a higher level of care is not a statement of hopelessness. It is actually a statement of hope, and that there is nothing that is more valuable than your recovery. I don't know anybody who has recovered who regrets having recovered from their eating disorder. And,
It's priceless.
it's priceless. It's priceless. And recovery is hard, hard work. I think that living life in whatever it is, everything it brings us things that are hard, that cause us to have trauma. A life well lived is not a life absent of trauma. It is a life that becomes resilient to trauma. It is not fair that people get eating disorders and they have to live with whatever recovery brought to them. But recovering from an eating disorder is a strength that no one can take away from you.
Oh, it gave me chills actually. Like, that's just so much. And this is why we do the work, right? If we were working with people who regretted the journey, regretted the misery that sometimes treatment can feel like, where would be the value for us as providers? And I really like to talk about that with my patients, frankly, that, hey, I'm not showing up for you for shits and giggles, truly. This is because I know that this is possible, and I can't see why you don't deserve that opportunity just like anyone else would. And so I'm here holding hope for you until you can have that hope yourself, and we'll get you there.
Yeah, I mean, because the eating disorders are liars and bullies, sometimes that turns out like the client will kind of see their treatment team as the liar or the bully. And I just have to gently remind them that I got better things to do than try to manipulate you. If I wanted to manipulate you, I would go sell you a diet online.
Yeah,
I'm not
totally.
overeducated, overworked to try to sell you a lie. I actually care about you becoming well. Otherwise I wouldn't be in this industry. And I can sometimes see their brains kind of click like, oh yeah. I'm like, I'm not lying to you. Your eating disorder is like, oh yeah, it is. So it's not always that easy, but it's a good reminder about why we talk about this stuff. And I was telling Dr. Wassenaar that some of my clients have fought me tooth and nail to not go to the hospital, and then later come around and say, oh my gosh, thank you. And I'm sorry for how I acted. And then I've had people fight me tooth and nail not to go to the hospital, and then later say like, I really should have gone, and I think I suffered too long. And it's so complex. It's so individual. Another metaphor I like to use is it's like cancer, where
Yes.
yes, it
I
depends.
was thinking the same thing.
Yes. What kind of cancer? How big is it? How aggressive is it? How long have you had it? And in general, we want to hit it with everything we got, which is what higher level of care can really do. Is if you start from the top, you have the most likely chance of eradicating and treating the tumor, and then kind of going down from there. That's not always the way it works out for complicated reasons, financial, motivation, willingness, but that's kind of like a rule of thumb. It's like, let's hit it hard, and then we have the best chance. Is that kind of what you would
Yeah.
say? Okay.
Absolutely. Absolutely. We know that if you can completely interrupt the eating disorder behaviors, whatever those look like for you, restriction, purging, exercise, compulsively weighing yourself, whatever it is, that you are more likely to be able to then start to practice without your eating disorder. Whatever it takes for you to be able to interrupt, however much support you need, it's the right amount of support.
Beautiful.
There's no judgment. It is what it is. And so
it's more
that's right.
It's not.
It's
It's
complete.
say like, oh, you have to have surgery on your broken leg. Like that's embarrassing. Like no, just
No.
that's what the
Or
diagnosis.
you have to have chemotherapy for your
And radiation.
cancer. Yikes. I mean, is that optional? No one says that.
They do to us though. They do to
They
us.
do to us.
But we understand why. So, okay, before we run out of time, we talked about myths about higher level of care that we want to kind of punch out of the room. So we talked about a few of them. One of the is that it's like going to prison. Will you address that one first?
Yeah. Yeah. I think that, people are, you hear a lot of things about eating disorder treatment and, how much is going to be taken away from you, how much of your autonomy is going to be challenged. And, I think that to the sort of previous conversation of it's going to take as much support as it's going to take. Your eating disorder is not going to like it. I am not saying eating disorder treatment is going to be easy. It is not. It is hard. It is the hardest thing you will ever do, and it is the most worthwhile. And so eating disorder treatment does often cause distress because we're challenging your eating disorder. But I think that there's a myth that eating disorder treatment units look like sunless, windowless, locked cages, or that you will be fed slop on a paper plate, or that you'll never see outside, or you'll be isolated from your friends and family and things that matter to you. And I would say I don't think that there's anything further from the truth. I could speak for my center, but I can also say that if you are in this field, it is because you want to provide compassionate, dignified care to people who are suffering from a terrible disease that is curable. And I think one of the things about eating disorder treatment that is so important to remember is that eating disorder treatment, in addition to all of the ways that we support your mental health, your psychiatric health, your medical health, your physical safety, it is a community-based treatment. So there is a community of people who have made the intentional decision to come challenge their eating disorder. And I think that for many people suffering with an eating disorder, you are alone out there in the world with your eating disorder saying, I'm your only friend. And coming to treatment, you are going to be with people who are living that life too and can understand you in ways that maybe nobody else can. Your eating disorder is going to hate that. It is selfish. It wants to be the only one you love. But I know so many people that have found some of their greatest allies in treatment and some of the people that are their lifelong supports as they live their lives. If you're fearful about what it is to be at a higher level of care, talk to your providers. Reach out and talk to the people who are working in these facilities. We are happy to tell you about what's really happening here. And I hope help you with that anxiety and that fear that's keeping you from your recovery.
Yeah, I mean, it sounds like these treatment centers are full of hope and community. in addition to care at the level that you need, which sometimes might feel difficult, but at its core, it's about like chemotherapy is not easy, right? But at its core, it's to try to heal you and help you. So taking away people's access to their disordered behaviors can feel very, very upsetting, vulnerable, and threatening. But of course, it's done with this belief and hope in recovery and then in the community, which leads to the other myth that we were discussing, which is is it contagious to be around people sicker than you? And are you going to get worse and get worse ideas being around people that might be sicker than you at the hospital?
Yeah, I think that to your point, being in treatment is a vulnerable time, but because you are taking away your sort of crutch, the eating disorder. So it is a time to be careful about how you are practicing recovery. I would say there are people who come to treatment who are not ready to challenge their eating disorder, and their eating disorder will take advantage of that. But if you are ready to live a life without your eating disorder, making the decision to come to treatment is the first shot across the bow of your eating disorder to say, you're not going to control me anymore. I know that all of you out there in podcast land can find all sorts of ways to reinforce your eating disorder. You don't need to come to treatment to find them. They're coming up on your Instagram feed. They're there.
You just wake up in the morning in the world and you'll get triggered.
That's right. That's right. So,
Well,
I think that while there will be people in treatment who may be struggling with their own motivation or how strong their eating disorder voice is, your decision to come to treatment and challenge your eating disorder is actually your strength. And you, I think, will be able to build resilience to your eating disorder by being around people who are in different phases of treatment.
yes, and just to add on that, I worked in outpatient group therapy for eating disorders for over a decade. Depending on the client, sometimes being in a group setting was the change agent for them. Like individual therapy is fantastic, but being able to see other people further down the road of recovery or back behind where they used to be in recovery was incredibly validating and motivating for people. So I think it can be such a unique and powerful way to kind of kickstart or continue or accelerate your change and recovery. And everything that's new is scary, but again, we have better things to do than lie to you, and we want you well. Right? We're believers in recovery and hope and change, and that you can live a life free of an eating disorder, which, as you were describing it, is kind of like an abusive, bliss partner. So he's putting you down and wants all your attention and all your energy back on the eating disorder.
Mic drop. Seriously.
Oh, so that ends our time for today. Dr. Wassenaar, it has been such a pleasure to have you here and have you share your expertise, your willingness to talk about levels of care at ERC, as well as other places that people might have nearby. Anything else you'd like to tell us about ERC before we log off?
Yeah, I would just say if you are curious about what we're doing at ERC, if this has piqued your interest and you're thinking maybe you want to know what higher levels of care might be available for you, we have a dedicated intake line with professionals in the field who can navigate that with you and answer your questions. There's no question that's too dumb, that's too basic. Everything is welcome to give us a call and talk about what are your options for treatment and what does recovery look like.
Beautiful. Thank you so much for being here. Thanks for coming.
Thank
Thank
you.
you.
Corinne Hannan.
I'm Dr. Knopf. Thanks, everybody.